Good morning, everyone. I am Dr. Sakshi, MBBS intern, and my topic for the seminar is lecanemab, and my mentor is Dr. Ayushi. So my presentation will be divided into basically two parts. First, I will be talking a bit about the Alzheimer's disease for which lecanemab has been approved recently. In Alzheimer's, a brief introduction, its pathogenesis, causes and risk factors, diagnosis, and the available treatment. And then I will be talking about the potential drug, lecanemab, its action, its efficacy, and the trial it underwent. Alzheimer's disease is a neurodegenerative disorder. It is the most common cause of dementia. There are over 10 million cases of dementia worldwide, implying one new case every 3.2 seconds. Coming to the pathogenesis, Alzheimer's is a disease in which amyloidosis occurs, which is a change in protein structure. It causes atrophy in brain cells. Now, it mainly affects the temporal lobe and parietal lobe, but the earliest part of brain to be involved is hippocampus, which converts short-term memory into long-term memory, and therefore there is amnesia. Now in our brain, there is a amyloid precursor protein, which is responsible for the repair and growth of neurons after its injury. It is generally broken down by alpha secretase with the help of gamma secretase, and it forms an alpha secretase product P3, which is non-toxic. But the problem arises when beta secretase starts to break it down with the help of gamma secretase, and it forms two products. One is amyloid beta gamma 2 peptide, which is toxic and amyloidogenic. And this is where the problem arises. And the next is a peptide, which is not toxic. Now, this amyloid beta gamma 2 peptide, it now reaches the brain cell and it forms the neurofibrillary triangles, which are intracellular, especially in the cortex. And the amyloid plaques are extracellular. These NFTs, they correlate with severity, which means that more are the tangles, the more severe will be the disease. These neurofibrillary tangles, they contain tau proteins. Tau proteins are essential for a cell because they help in stabilizing the microtubules. But in Alzheimer's disease, they become hyperphosphorylated. Here is a picture. This is a healthy neuron. These are the stabilizing tau molecules. Now, when the tangled clumps of tau proteins are formed, that are hyperphosphorylated tau proteins, the microtubule subunits starts to fall apart. Causes of Alzheimer's disease, there are mainly two categories: early onset Alzheimer's disease and late onset Alzheimer's disease. Early onset or familial, onset age is less than 65 years. It amounts to around 5% of Alzheimer's disease. The genes involved are amyloid precursor protein, pre-selenin 1, which is formed due to chromosome 14 mutation, and pre-selenin 2 due to chromosome 1 mutation. Late onset Alzheimer's disease, onset age is more than 60 to 65 years. It amounts for 90 to 95% of the cases, also known as sporadic. Genes involved are ApoE, E4. Now the risk factors for Alzheimer's disease. High risk factors include if a person has a family history of Alzheimer's disease, if age is more than 70 years, females, because they generally have a longer life than males, gene which is ApoE4. ApoE gene is generally responsible for the destruction of amyloid plaques, but when it converts into E4 subunit, it is less effective. Diabetes, hypertension, poor dietary intake, and poor education. Low risk factors include ability to express complex written language in early adulthood, ApoE2 gene, non-steroidal anti-inflammatory drugs use, and smoking. Clinical features are divided into two parts: cognitive symptoms and non-cognitive symptoms. Cognitive symptoms include impaired memory, impaired judgment, impaired abstract thinking, impaired language, impaired orientation, impaired praxis or movement, and impaired attention. Non-cognitive symptoms include negative symptoms like apathy, depression, positive symptoms like irritability, agitation, and psychotic symptoms like delusion. In a living patient, it is there is not a definitive diagnosis, but we can still rule out the amyloid beta plaques burden through amyloid PET scans and CSF analysis. But the definitive diagnosis is a post-mortem finding, brain cell biopsy after autopsy. We can look for neurofibrillary tangles, senile neuritic plaques, which correlates with age, and these are extracellular. We can look for cerebral amyloid angiopathy. It occurs when the amyloid starts accumulating in the blood vessels. It can accumulate in larger blood vessels or smaller blood vessels. And we can also look for granulovascular degeneration. For the treatment of Alzheimer's, these are only helpful in reducing the symptoms of Alzheimer's, but not treating it. We use cholinesterase inhibitors because in Alzheimer's, there is a sequential degeneration of nucleus basalis, and therefore the level of acetylcholine goes down, and therefore we give cholinesterase inhibitors like donepezil, galantamine, and rivastigmine. We can also give N-methyl D-aspartate inhibitors like memantine. Now I will talk about lecanemab. It is a humanized monoclonal antibody. It generally binds to the amyloid beta protein, and it marks them for destruction by microglia. It was jointly developed by ESI and Biogen. The trial, it was conducted on November 29, 2021. It was one of the largest trials conducted. 1795 patients were involved. It was a randomized, multi-center, double-blind, placebo-controlled clinical trial, which went on for 18 months. Now, 1,795 adults were there. Half of the adults were given intravenous lecanemab. Dose was 10 mg per kg every 2 weeks versus placebo. Now, the results of the trial were ruled out on the basis of the clinical dementia rating. Here are the domains of clinical dementia rating. There are 6 domains: memory, orientation, home and hobbies, community affairs, personal care, judgment, and problem solving. This is according to the score, we determine the stage. If it is 0, normal; 0.5 to 4, questionable cognitive impairment; 0.5 to 2, questionable impairment; 2.5 to 4, very mild dementia; 4.5 to 9, mild dementia; 9.5 to 15.5, moderate dementia; and 16 to 18 is severe dementia. The results of the trial were as follows. Basically, we looked for the change from the baseline. This is adjusted mean change from baseline, and it indicates the worsening of the symptoms. For lecanemab, the mean change was 1.21, and for placebo it was 1.66, which indicates that in patients where lecanemab was given, there was a slower cognitive impairment. Lecanemab decreased cognitive decline by 27% than placebo. Difference of points was by 0.45. Change in baseline 1.21 for lecanemab and 1.66 with placebo. Some side effects included infusion-related reactions and amyloid-related imaging abnormalities. On January 6, 2023, lecanemab gained accelerated approval by the US FDA for medical use in the States. It is sold under the brand name of Leqembi. Ongoing trials are assessing the efficacy of subcutaneous administration and whether lecanemab can prevent onset of dementia in patients with amyloid pathology, but no clinical symptoms. It is the second drug after aducanumab to be approved by the US FDA for Alzheimer's. These are my references. Thank you.
Will you push it ahead?
Good morning, everyone. I am Dr. Sachi Bansal, MBBS intern of batch 2017. Today, the topic of my presentation is Role of Nutraceuticals in Psychiatry, and my moderator is Dr. Abhishri Ranjan ma'am. The question is, what are nutraceuticals? The term nutraceutical is borrowed from the fusion of nutrition and pharmaceuticals. They are described as food components or active principle present in elements which have positive effects for health and quality of life, including preventing or treating disorders. Herbal and natural food supplements are increasingly used to treat different psychiatric disorders, often as self-prescribed therapies for many reasons, some of which are availability, affordability, safety, or their belief in traditional cures. They also reduce the use of expensive and sometimes unuseful therapies. The following is the image showing various types of nutraceuticals: dietary supplements, micronutrients, functional foods, terpenoids, polyphenols, and glucosinolates. Nutraceuticals are used in the following areas in psychiatric practice. For the four most common mental or mood disorders causing disabilities, that is depression, bipolar disorder, schizophrenia, obsessive compulsive disorder. For anxiety disorders, post-traumatic stress disorder and panic disorders. For eating disorders like anorexia nervosa, bulimia nervosa, pica, etc. For attention deficit disorder or attention deficit hyperactivity disorder. For autism, for headache, and incognition during aging and related disorders. The following is the table in which certain nutraceutics and their action and utility in mood and anxiety related disorders is given. The first nutraceutic is St. John's wort. It is known to contain many potent constituents. It has been known to show mild serotonin reuptake blocking properties, while there is little evidence of any significant monoamine oxidase inhibition. They are also known to enhance GABA receptors. Hence, it is used in depression and mild anxiety. Omega-3 fatty acids. They are known to show antioxidant and anti-inflammatory activity. They are used in depression, bipolar mood disorders, and schizophrenia as an adjunctive treatment. Folate, it plays an important role in the formation of S-adenosylmethionine, and it is used in depression. Vitamin B12, it is also used in depression, and it helps in the formation of S-adenosylmethionine. S-adenosylmethionine, it increases the synthesis and activation of serotonin, norepinephrine, and dopamine, and is used in depression. Alpha-lactalbumin, it is a whey-derived protein which is present in human milk. It increases 5-HT synthesis and is used in depression. Inositol, it is known to have desensitization in 5-HT receptors. It is used in depression and anxiety. Kava, it helps in the modulation of GABA ionic channels and inhibition of sodium reuptake. It is used in anxiety disorders. Valerian, it is known to reduce GABA catabolism, and it increases the transmission of GABA and interaction with GABA receptors. It is used in anxiety and insomnia. Passion flower, it has benzodiazepine-like interaction with GABA receptors and is known to have effects in anxiety and insomnia disorders. Nutraceuticals for the treatment of bipolar disorder. Nutraceuticals can target biological processes including neurogenesis, inflammation, oxidative stress, and mitochondrial function, which are all known to be dysregulated in bipolar disorder. Omega-3 fatty acids are known for their anti-inflammatory properties. Vitamin D is known as an antioxidant. Coenzyme Q10 are involved in mitochondrial biogenesis. Amino acids such as N-acetylcysteine has shown effects in bipolar disorder. Nutraceuticals for headache. Several guidelines have incorporated nutraceuticals for migraine prevention, including American Academy of Neurology, American Headache Society, the Canadian Headache Society, and European Federation of Neurological Sciences. The nutraceuticals included for the purposes of this review are riboflavin, vitamin B2, coenzyme Q10, magnesium, vitamin D, and melatonin. Although not considered a nutraceutical, cannabis is also considered in many reviews. Cannabis is also considered in many reviews as a larger number of headache patients are turning to cannabis to self-medicate as legalization has become more widespread. Other natural and herbal supplements evaluated for headache include ginkgolide B, butterbur root extract, St. John's wort, feverfew, and damask rose. Nutraceuticals intervention in cognitive decline during aging and disorders. Based on chemical constituents, they are categorized as polyphenols, which includes flavonoids, anthocyanins, isoflavones, flavanones, coumarins, tannins, lignins. This image shows plant polyphenols. Isoprenoid derivatives, which include saponins, carotenoids, terpenoids, tocotrienoids, tocopherols, terpenes. Carbohydrate derivatives, which includes ascorbic acid, oligosaccharides, non-starch polysaccharides. Fatty acids and structural lipids, amino acid derivatives, micronutrients, which includes vitamins, minerals, and microbes, which includes probiotics and prebiotics. The following are the references. Thank you.
Good morning, everyone. I'm Sahil Gandhi, MBBS intern, batch 2017, and I'll be Good morning, everyone. I'm Sahil Gandhi, MBBS intern, batch 2017, and I'll be presenting on the topic effect of psychotropic drugs on the menstrual cycle. So here we can see that this is a main pathway which is involved in the communication between the antipsychotic drugs and their side effects. That is mainly the amenorrhea. This is the tuberoinfundibular pathway, which is starting from the hypothalamus and going to the pituitary. As we all know that the dopamine inhibits the prolactin levels, that is, they have a inverse relationship. Here we can see the role of antipsychotic medications in amenorrhea. The mechanism by which antipsychotics stop menstruation is hyperprolactinemia secondary to dopamine blockade. Elevated prolactin levels leads to disturbances in the secretion of gonadotropin releasing hormone, which results in menstrual irregularities and amenorrhea. Hyperprolactinemia is induced mainly by first generation antipsychotic drugs, that is amisulpride and risperidone. Here we can see the comparative effects of different antipsychotic medications on the prolactin concentration. We can see the prolactin sparing drugs, which are aripiprazole, asenapine, brexpiprazole, cariprazine, clozapine, iloperidone, lumateperone, pimavanserin, quetiapine. And here we can see a low-risk drug which slightly increases the levels of the prolactin, lurasidone, olanzapine, and ziprasidone. The drugs which are high risk are amisulpride, paliperidone, risperidone, sulpiride, and FGAs. Now here we can see how we can manage the amenorrhea caused by the drugs which are causing hyperprolactinemia. What we can do is we have to check levels of prolactin in the blood at regular intervals, that is 3 months. If these are the normal levels which are given in women and men. If the prolactin levels are elevated, then we can use the adjunctive drugs, mainly which is aripiprazole. So a summary of the management of hyperprolactinemia is the first choice of drug is aripiprazole, and the other drugs which we can use are dopamine agonists, that is cabergoline, bromocriptine, amantadine. We can also use metformin along with them, and we can also use peony glycyrrhizide decoction. There are some contraindications we should keep in mind before giving the prolactin-raising drugs. These contraindications are as follows. Patients who are under 25 years of age, patients with osteoporosis, patients with a history of hormone-dependent breast cancer, and young women. Now we'll move towards the antidepressants and how they affect the menstrual cycle. Now there are two mechanisms which are explained for the increasing levels of prolactin by the antidepressants. First of all, we understand that how depression leads to suppression of the reproductive hormones. First of all, stress released to the release of cortisol releasing hormone. It will cause a release of ACTH and then cortisol, which will suppress every reproductive hormone, that is gonadotropin releasing hormone, luteinizing hormone, follicular stimulating hormone, and estrogen. These are the receptors on which antidepressant acts and causes hyperprolactinemia. Prolactin release is controlled by endogenous dopamine, but is also indirectly modulated by serotonin via stimulation of 5-HT1C and 5-HT2 receptors. Now, these are some antidepressants, and along with their prospective studies, case reports, and case series, which have been proven to cause the effects on prolactin. Mainly, the effects are seen with the MAO inhibitors and tricyclic antidepressants on the prolactin levels. Generally, the SSRIs and SNRIs do not show any changes in the prolactin levels when they are given. As we all know that the antidepressants are also used in the premenstrual dysphoric disorder, which is characterized by debilitating mood and behavioral changes in the week preceding menstruation that interferes with normal function. Now, these are the drugs which are used in premenstrual dysphoric disorder. Sertraline, paroxetine, fluoxetine, and fluvoxamine have been reported to reduce the symptoms of PMD. Controlled trials of fluoxetine and sertraline administered either throughout the cycle or only during the luteal phase, the 2 weeks between ovulation and menstruation, showed both schedules to be equally effective. Now we move towards the methamphetamine and its relationship with the menstrual cycle. Long-term use of methamphetamine disrupts the menstrual cycle and HPO axis, that is hypothalamic pituitary ovarian axis. Hypothalamic and pituitary hormonal regulation may be the main mechanism of menstrual abnormality after long-term methamphetamine use. Discontinuance of methamphetamine might slowly restore the sex hormone regulation. Weight loss may be an important cause of the hormonal changes. However, weight restoration was not related to the recovery of hormone regulation. Now, there are some studies which also correlates the lithium and valproate serum fluctuations within the menstrual cycle. Some women with mood disorders complain of worsening during the late luteal phase of the menstrual cycle. As one explanation of symptom exacerbation might be a fluctuation of lithium and valproic acid serum levels concurrent with cyclic hormonal fluctuations. Lithium, which we all know that it also leads to hypothyroidism, which can obviously will cause to dysregulation of menstrual cycle. Valproate is also known to cause PCOS. These are the two mood stabilizers which we have already talked about, lithium and valproate, which also leads to the disruption of menstrual cycle and PCOS respectively. Thank you.
Good morning, everyone. Myself, Dr. Sajita Chaudhary, and I am going to present on topic NMDA receptor antagonist and their role in psychiatry. And my moderator is Dr. Aditi. So first, we will talk about glutamate. What is glutamate? It is an excitatory neurotransmitter. It is formed when glutamine is converted to glutamate within presynaptic neurons by enzyme glutaminase, and it is taken up into synaptic vesicles by vesicular glutamate transporter, that is VGLUT, stored for future release. Glutamate receptors are further divided into two types, inotropic and metabotropic receptors. The inotropic receptors are further divided into three subtypes: the AMPA, that is alpha amino 3 hydroxy 5 methyl 4 isoxazolepropionic acid receptor, the kinase receptor, and the NMDA, that is N-methyl D-aspartate receptor. This representation shows the division of glutamate receptors into inotropic and metabotropic. Metabotropic receptors are further divided based upon mGLUR1 into group 1, 2, and 3. NMDA receptors, these are blocked by magnesium at a resting membrane potential. NMDA receptors are silent until activated AMPA receptors have been sufficiently depolarized the neuronal membrane. NMDA receptors require simultaneous binding of two ligands to two separate recognition sites in order for channel to open, which is NR1 and NR2. This is a schematic representation showing NMDA receptor complex with a glutamate recognition site, glycine site, and a polyamine site. The type of NR2 subunit fits pharmacology and biophysics of NMDA receptor function. NR2A is expressed in a corticolimbic region. NR2B is expressed at high levels in immature cortex. NR2C is present in cerebellum, and NR2D is located in cerebellum and midbrainstem. So next we'll talk about excitotoxicity. First thing is that glutamate can be harmful to neurons' health. Release of too much glutamate or administration of too much glutamate agonist can cause excitotoxicity. Neurons can be literally excited to death following exposure to too much glutamate. Although the mechanisms are still debated, a predominant theory is that excitotoxicity is related to calcium entry through NMDA receptor channels. When a neuron is spontaneously exposed to glutamate, the cell membrane will be highly depolarized and an abnormal amount of calcium will enter the cell through NMDA receptor channels. Over time, the effects of enzymatic processes induced by excessive calcium entry will cause neuronal death. Excitotoxicity is often seen after strokes and other events that causes neuron to die, rupture, releasing their intracellular contents. This excessive extracellular glutamate around the neurons that survived the initial traumatic events, such that causes these nearby neurons to eventually die because of excitotoxicity. This process can occur in a wave with the death of group of neurons, causing subsequent excitotoxicity of neighboring neurons. Next, we'll talk about the drugs acting on NMDA receptor. First, we'll talk about NMDA antagonist, that is memantine. Its mechanism of action is it is an NMDA receptor calcium channel blocker and protect the neuron from calcium-mediated neurodegeneration, which forms basis for pathophysiology of primary dementia. It is used for treatment of moderate to severe Alzheimer's disease. This drug is thought to be preferentially blocking by reversibly opening NMDA channels. Several randomized studies have been conducted to determine the efficacy of memantine in Alzheimer's disease. According to main results, memantine monotherapy significantly improves various aspects of disease such as behavior, activities of daily living, and global function. However, it has been found that the efficacy of drug is small and there is limited evidence of its clinical benefit. Despite large number of clinical studies of use of memantine in Alzheimer's disease, data on its interaction with human cell membranes is scarce, and previous studies have proposed qualitative models on reaction kinetics and molecular orientation in lipid biopsies. So next drug we'll talk about is amantadine. Amantadine is a weak, non-competitive NMDA receptor antagonist. It is used in treating Parkinsonism and drug-induced extrapyramidal side effects, but its efficacy in this area is questionable. Next drug is ikemprostate. Its mechanism of action is it acts as an agonist at GABA A receptor, weak antagonist at NMDA receptor, and some opioid antagonistic activity, and increases 5-HT levels. It is approved for use of alcohol de-addiction and decreases drinking frequency, reduces relapse drinking in abstinent phase. It is usually administered in the dose of 1.3 to 2 grams per day. Next, we'll talk about alcoholism. Ethanol at concentration associated with intoxication has dual action of enhancing GABAergic receptor function and attenuating NMDA receptor function. The GABA receptor effects may be associated with anxiolytic effects of ethanol. Persistent abuse and dependency on ethanol results in downregulation of GABA receptors and upregulation of NMDA receptors, such as acute discontinuation of ethanol results in hyperexcitable state known as delirium tremens. Now we'll talk about the drugs such as ketamine, which are also dissociative anesthetics. The theory that hyperfunction of NMDA receptor is an etiologic factor in schizophrenia arose from observation that phencyclidines and relative dissociative anesthetics that block NMDA receptors produce a syndrome that can be indistinguishable from schizophrenia. In fact, under lab conditions, low-dose infusion of ketamine can produce the positive symptoms, the negative symptoms, and specific cognitive effects associated with schizophrenia in clear consciousness. Subsequent studies have shown low-dose ketamine can enhance amphetamine-induced subcortical induced dopamine release as it is observed in schizophrenia, as well as abnormal cortical events related to potential and disruption of pre-pulse inhibition in experimental studies. Next, we will talk about how NMDA receptors are these days acting as a target for treatment in depression. Therapeutic goals have been focused on neurotransmitters such as glutamate and its receptor, and particularly on the inotropic NMDA receptors. In past decade, clinical investigations have shown that single intravenous bolus administration of non-competitive NMDA receptor antagonists such as ketamine evoked a rapid, that is only within 2 hours, and sustained antidepressant action. Interestingly, the dosage of ketamine used for antidepressant action is comparable to one used to evoke psychotic events in healthy volunteers. Thus, it seems ketamine can exert similar enhancing modulatory function in mental status, that is increasing emotional condition and mood in depressives and increasing extremely disordered thinking and behavior in healthy controls, and both the conditions can be triggered by stress. Although mechanism of action is not completely understood, the involvement of several cellular and molecular processes have been unveiled. Hence, its antidepressant-like action require activation of another class of inotropic glutamate receptors that are alpha receptors, and that is AMPA receptors, that is alpha amino 3 hydroxy 5 methyl isoxazole propionic acid receptors. And approval of S isomer of ketamine has come with serious restriction because drug can cause dissociation and delirium at low dose used for depression. These adverse effects appear shortly after infusion onset but vanish just before antidepressant response begins. In attempt to overcome such problems, other ketamine-based alternatives have been pursued, and the approved ketamine has S-ketamine has fourfold greater affinity for NMDA receptors than R-ketamine. And now, at last, we will discuss about the NMDA receptors and schizophrenia. Although hyperfunction of NMDA neurotransmission has been shown to play an important role in pathophysiology of schizophrenia, the results of clinical trials of NMDA enhancing agents have been inconsistent, since direct agonist of NMDA receptor can produce severe excitotoxic effects, and therapeutic focus turned to the obligatory glycine co-agonist site of NMDA receptors, that is the NMDA glycine site. Thus, drugs stimulating the NMDA glycine site were postulated to be effective in treating symptoms of schizophrenia. Studies carried out in lab showed that NMDA receptor antagonist MK801 elevated release of glutamate and 5-HT in medial prefrontal cortex. Results showed that typical antipsychotics such as haloperidol, chlorpromazine, and atypical antipsychotics such as clozapine and olanzapine were able to attenuate the excess prefrontal glutamate, but only atypical drugs were further able to reduce excess of prefrontal 5-HT. Thus, further results suggest that blockage of exacerbated 5-HT release in medial prefrontal cortex induced by NMDA receptor antagonist can be a good indicator of atypicality of antipsychotic drugs. And preclinical studies have shown that 5-HT2A antagonist and 5-HT1A agonist can elevate the cognitive defects induced by NMDA antagonist. Each of these receptors do not confer antipsychotic individually, so likely the combined effect is needed. These are my references, and thank you.
Wait for the any question. Any mortality with that chemical? New monoclonal antibody? Any mortality? There was a previous drug, so there was a lot of controversy. Similarly, this one also. No controversies with this, because there was a report that few of the members resigned. FDA. Why it was fast track? Extraordinary approval to see it. Cannabis was necessary to put. It was mandatory. It's not a nutraceutical, so why it? You said first generation antipsychotic, risperidone, anisulpride.
Yes.
Is that so? So does ketamine really blocks NMD? If you go to ketamine, but it increases. Glutaminergic function ultimately it increases or decreases. Actually, go into subsequent neurophysiology of it. Actually, in turn leads to increase in glutaminergic function. So it's a very soft kind of a thing. Subsequently, you see, you eat it, it will actually increase the calcium flow and can cause excessive toxicity. That is why it will cause all those kinds of. All of you spoke very well. When you introduce a topic, we call it introducing the hero. Like you will go for some background, then we subsequently are introducing the topic. So first speaker took a lot of time to introduce a topic, and Dr. Gandhi immediately jumped. No need, antipsychotic induced prolactin for the first slide. So maybe you can balance it up. You learn with time. You all spoke very well. I think it was a very professional presentation. You need not patch a lot of stuff in your slides that can take off the audience attention. You need to only put up key points. As the first speaker spoke very well, few things she spoke impromptu by herself. those were not put in the slide. So you need to give only keywords in the slide. Subsequently, you need to speak those by your own memory or by your practice. Dr. Veena Sikra. Yes. क्या बोली थी? Roasted. क्या लिखा भी वैसे? The slides were very good. Her slide was weak initially. Then subsequently, I thought that after making the presentation, you lost interest. Yeah, let me patch up everything. 4, 5, 6 slides are fine, and then that happens to us also. At times, the last minute. So if you people have presented better, we would have been in your place. We have given complex. Giving a PPT presentation of these qualities are very encouraging. Wherever you will join, please will be acceptable. Thank you. Let's start the round. Yeah. Yeah. ठीक है तो बाहर से समझाना ही हमारे गवर्नमेंट सुनेंगे और मेजर पैरामीटर सेट में जाएंगे तो फिर सब ठीक होगा समझाने के ठीक है ठीक है ठीक है नहीं बोलना भी तो there's a discrimination. So, but NMDA और इनको बढ़ना ऊपर और एक्चुअली बेसिकली शेड्यूल देते हैं कि आप तो शेड्यूल कैसे करते पर ये बेसिकली ब्रॉडली डजंट प्लॉट टुवर्ड्स द ब्लॉक वो भी बेसिकली पता चलेगा वेरी